Hello everyone. The class for today will be on urticaria and angioedema. Um, to understand first what urticaria and angioedema is, we should know what exactly a wheal is called. A wheal is a primary skin lesion which is derived from the Latin word urtica, meaning stinging nettle. This is the urticaria word derived from the word urtica. It is a cutaneous reaction pattern consisting of transient dermal swellings in the form of wheals or angioedema. Individual wheals are pruritic, pink, or pale swellings of superficial dermis that have a red flare around them and usually subside within 24 hours. In angioedema, there is a deeper swelling which is less well defined. It is more painful rather than itchy, less erythematous, and it involves deeper tissues such as hypodermis and the subcutaneous submucosal tissues. It takes usually more than 24 hours to resolve. Urticaria can be mast cell dependent, in which the mast cell degranulate and release histamine and other mediators, which can be further IgE dependent or non-IgE dependent. And other form of urticaria can be mast cell independent, where the mast cells are not the main mediators of urticarial wheals. In some instances, the mast cells are directly activated by molecules such as substance P, morphine, codeine, complement 5A. The activation is independent of immunoglobulin E, and such activation is referred to as non-immunological mast cell activation. There can be preformed mediators and new mediators synthesized by mast cell in response to the degranulation. The preformed mediators within the mast cells are histamine, heparin, and proteases like tryptase. New mediators that are synthesized once the stimulus is provided to the mast cells. These are prostaglandin D2, the leukotriene C4, D4, and E4, and the platelet activating factor. Various stimuli can lead to urticaria which are independent of mast cells. Vasoactive stimuli such as sorbic acid, etc., bradykinins, C1 inhibitor deficiencies, hereditary causes, acquired causes, and ACE inhibitor induced urticaria is mainly mast cell independent. This is just a pathogenetic mechanism. The allergens and autoantibodies against the immunoglobulin E and substance P, morphine, codeine, complement 5A, etc. These both activate the mast cells and they degranulate to release histamines and other leukotrienes. Whereas the mast cells independent ones, the various precipitating factors being the sorbic acid, food additives, bradykinin, etc. And these mainly lead to vasodilation and increased permeability, leading to wheal and angioedema. Histamine is the main mediator. The role of histamine in the blood vessel is vasodilation, thereby leading to erythema and edema. Histamine also stimulates the nerve endings, which thereby leads to pruritus and axon reflex and flare. The urticaria is classified broadly into two, the acute urticaria and the chronic urticaria. Any urticaria with a duration overall of less than 6 weeks is termed as acute urticaria, whereas the chronic urticaria is the one which is more than 6 weeks old. Most common causes of acute urticaria are infections and even infestations, drugs, food additives, and idiopathic. Chronic urticaria, mostly classified as chronic spontaneous urticaria, which can be autoimmune in etiology, a pseudo-allergic phenomena, an infection, or idiopathic, physical or inducible urticaria, such as the pressure urticaria, and urticarial vasculitis, which is mainly drug-induced. Angioedema is further classified as angioedema with wheals, which when it is associated with urticaria, and without wheals when we just have swelling in the mucosal surfaces, mainly on the lips, eyes, periorbital tissue. The angioedema without wheals can be mainly due to hereditary angioedema and ACE inhibitor associated angioedema. Urticaria rarely progresses to anaphylaxis, but this one is often a feature of angioedema. Now, the causes of urticaria, exogenous causes being allergens and pseudoallergens, pollens, house dust, fungi. These are all inhaling allergens which can lead to urticaria. Fish, egg, brinjal, soy, milk, chocolate, nuts, etc., which are high protein diets, when ingested, can lead to urticarial wheals. And several drugs such as non-steroidal anti-inflammatory drugs, polymyxin, vancomycin, morphine, codeine, penicillins, and cephalosporins are some of the known drugs which cause urticarial responses. Nuts, fishes, chocolates, spices, these act through type 1 hypersensitivity, which is IgE mediated, and these thereby lead to urticarial wheals. Chronic urticaria is mainly due to the food additives such as sodium benzoates and salicylates, and these act by pseudoallergic mechanism and direct mast cell activators and not IgE dependent. The endogenous agents that lead to urticaria may be infections which can be gastrointestinal, respiratory, or urinary tract. The bacterial, protozoal, helminthic infestations, viral infections such as cytomegalovirus, Epstein-Barr virus, herpes simplex virus, etc. Systemic diseases such as Hashimoto's thyroiditis, systemic lupus erythematosus, chronic active hepatitis, and malignancies can also have urticaria as one of their clinical manifestations. Physical urticaria can be subdivided into dermographism or urticaria factitia, which is the most common type and is manifested by red, itchy, linear wheal appearing immediately after light stroking of the skin, and the eliciting factor being mechanical forces or shearing forces which cause whealing and erythema in 1 to 5 minutes. Another variant of physical urticaria is cold contact urticaria, where there is urticarial wheal response on contact with cold objects, cold air or fluids. Heat contact urticaria, where localized heat is the eliciting factor. Solar urticaria, which is elicited by ultraviolet or visible light. And delayed pressure urticaria, which is mainly due to vertical pressure. 3 to 4 hours, 12 hours later, the urticarial wheals arise and they appear at the site of the pressure of the skin. They are painful rather than itchy and may last for more than 24 hours. Vibratory urticaria, where the vibrating forces are the eliciting factors, aquagenic urticaria, cholinergic urticaria. This type of urticaria mainly manifests as 2 to 4 millimeter small erythematous papules, which are surrounded by pink flare, most commonly seen on trunk and proximal limbs. The increase in the core body temperature, which can be due to exercise or weather or hot spicy food, can be an eliciting factor for cholinergic urticaria. Contact urticaria, contact with those substances which are known to degranulate mast cells. Exercise-induced urticaria or anaphylaxis can be due to excessive physical exercise. The clinical features of urticaria, the most common and the most important feature is pruritus. What we find on examination are wheals or hives, which are pale, pink, well-defined swellings, which spread on scratching and coalesce to form larger lesions. The lesions usually last for 90 minutes to 24 hours. The differential diagnosis of urticaria includes urticarial vasculitis, eosinophilic cellulitis, bullous pemphigoid, and urticarial drug eruptions. These are not transient lesions and last more than 24 hours, so this can be a differentiating feature. Urticaria and urticarial vasculitis are very close entities which need to be differentiated because urticarial vasculitis is mainly a drug-induced urticaria and that needs to be managed on a more aggressive basis. Urticaria results in generalized body involvement, whereas urticarial vasculitis usually presents on trunk and proximal limbs. In urticaria, individual lesions last less than 24 hours, and in contrast, in urticarial vasculitis, these lesions last more than 24 hours. The lesions are quite itchy in urticaria, whereas painful and burning in urticarial vasculitis. Urticaria lesions don't leave behind a post-inflammatory pigmentation, they resolve, leaving behind a normal skin. Whereas post-inflammatory pigmentation, a purpuric center or a purpuric lesion, a leftover lesion can be very commonly seen in urticaria vasculitis. Biopsy does not reveal vasculitis because it is just an inflammatory response which subsides in few minutes to hours. And urticaria vasculitis is associated with systemic symptoms also. And on histopathological examination, we see a vasculitic-like picture. Familial cold autoinflammatory syndromes and paraneoplastic syndrome also present with urticaria lesions, but these lesions are non-itchy and are associated with systemic symptoms and usually arise in infancy and childhood. Few examples being Muckle-Wells syndrome and Schnitzler syndrome. Chronic urticaria which has been present on and off for more than 6 months, 6 weeks duration. The duration of the urticaria can help us in diagnosing even the cause behind it. If it lasts for 1 hour, it's physical urticaria. For less than 2 hours, contact urticaria. 1 to 24 hours, spontaneous urticaria and delayed pressure urticaria. And if an urticaria lesion lasts for more than 24 hours, a possibility of urticarial vasculitis should be considered. Chronic urticaria is usually found commonly in association with thyroid disorders, mostly hypothyroidism, atopic disorders, vitiligo, pernicious anemia, and rheumatoid arthritis. A careful history is very important to rule out the precipitating cause in patients of urticaria, which include travel and work history, ingestion of foods, medications, herbs, and vitamins, recent infection, known allergies or atopy, and family history of allergy or thyroid diseases. There is an urticaria activity score which grades it from 0, 1, 2, and 3. No wheals present and no pruritus present, then we grade it as 0. Less than 20 wheals and mild pruritus, grade 1. 20 to 25 wheals in 1 day or 24 hours and moderate, troublesome but not interfering with sleep, pruritus is graded as 2, and severe with more than 50 wheels and severe troublesome pruritus interfering with normal daily activity and sleep is labeled as grade 4. Usual investigation that we plan in patients of urticaria is complete blood count, more importantly hemoglobin total count, the urine analysis, stool analysis, erythrocyte sedimentation rate, and skin biopsy if the lesions are present for more than 24 hours. The provocation test for physical urticaria, dermographism. Stroking of the skin by a blunt object results in appearance of the wheals, linear wheals, as seen in patients of urticaria. A delayed pressure urticaria can be elicited by locally applying a weight for 20 minutes. Cold urticaria can be elicited by applying a cold object such as ice cube for 20 minutes. Physical exercise in hot baths if precipitate urticaria can be a reason for cholinergic urticaria. Aquagenic urticaria precipitates by contact with water. Exercise urticaria or exercise anaphylaxis usually is precipitated by exercise, and solar urticaria can be elicited by phototesting. This is what dermographism is. If we stroke the skin in a particular manner, there is a wheal and a flare response. Hereditary angioedema is a recurrent laryngeal edema or a colicky abdominal pain accompanied by skin swelling, especially on distal limbs. It may be preceded by a reticular erythema. Family history is usually present and it is supposed to be an autosomal dominant disorder. Trauma, estrogens are common triggers. The patient suffering from hereditary angioedema usually lacks C1 esterase or C1 inhibitor. Bradykinin acts on vasculature and results in angioedema. Attacks can be life-threatening and are associated with arthralgia. It can be diagnosed by low level of serum C4. Acquired angioedema due to lymphomas, SLE, etc. has low C1q levels along with C4 levels, but these are just sensitive tests and not diagnostic. Treatment of urticaria, the first thing is rule out anaphylaxis. If at all the precipitating agent has been identified, it should be discontinued. The idiopathic nature of chronic urticaria and possibility of inability to identify a specific cause should be discussed and ruled out. The European Academy of Allergy and Clinical Immunology guidelines suggest that the first use of second generation antihistamine is the first line therapy. The second step includes increase in the dose of the antihistamine by fourfolds. The third step being antihistamine in cases of antihistamine refractory patients, cyclosporine, montelukast, or other drugs, biologics such as omalizumab can be added. And the fourth step is addition of dapsone, colchicine, hydroxychloroquine, ranitidine, lithotrexate, or azathioprine. The first generation H1 antihistamine in standard dosages can be given for 1 to 2 weeks. If they are unable to control the urticaria, a fourfold increase in the dosage is the second step. Thereafter, if at all the response is poor, omalizumab, cyclosporine, montelukast can be added along with the first generation antihistamines. And the last step could be addition of dapsone, colchicine, hydroxychloroquine, and methotrexate. The second generation H1 antihistamines are the cornerstone in the treatment of urticaria. The commonly used drugs are cetirizine in the doses of 10 mg per day, levocetirizine 5 mg per day, fexofenadine in dose of 180 mg per day, loratadine 10 mg per day, and desloratadine in the dosage of 5 mg per day. Second generation antihistamines, H2 antihistamine is the ranitidine, famotidine, and cimetidine, whereas the ranitidine is the most commonly used drug in India. It can be added to the first generation antihistaminics, the H1 antihistaminics rather, in the dose of 150 mg twice daily. The leukotriene receptor antagonists such as the montelukast and zafirlukast are other drugs that can be used as adjuncts if the response to antihistamines are poor. Oral corticosteroids are very much useful in cases of acute urticaria, but not in cases of chronic urticaria or in acute exacerbations of chronic urticaria, because in cases of chronic urticaria, the treatment has to be given for a long time. And that can be a risk factor for appearance of side effects of oral corticosteroids. So, severe angioedema, delayed pressure urticaria, and urticaria vasculitis are other indications where you can use oral corticosteroids. Omalizumab is a humanized monoclonal antibody against immunoglobulin E, and it was approved in 2014 by the US FDA for the treatment of urticaria. Dose recommended is 300 mg monthly, given subcutaneously. Therapy for physical urticaria and symptomatic dermographism on H1 receptor antagonist should be sufficient. In delayed pressure urticaria, systemic corticosteroids, NSAIDs, sulfasalazine, dapsone, montelukast. In cholinergic urticaria, H1 receptor antagonist, danazol. In cholinergic urticaria, the roles of chlorpheniramine maleate is specially mentioned, because that is the drug that should be the drug that needs to be given initially, and it helps in control of the symptoms very nicely. Cold urticaria, H1 receptor antagonists, ketotifen, cyproheptadine, systemic corticosteroids, and epinephrine can be given. In solar urticaria, induction of tolerance by phototherapy, sunscreen, and hydroxychloroquine are other modalities of treatment. Most common thing, most important thing in physical urticaria should be the avoidance of the precipitating factor. 3 months of good control is recommended prior to the tapering therapies, and it can be longer for the patients with one or more of following characteristics. That means that symptoms which are present for years, very severe symptoms and difficult to control, and concomitant physical urticaria, in such patients, the tapering should be very slow and over a longer period of time. For hereditary angioedema, danazol is the maintenance therapy. For acute attacks, fresh frozen plasma is treatment of choice. And the newer available drugs such as Berinert, Ruconest, Icatinib, and Icalitinide are the kallikrein inhibitors are mainly used for therapy of hereditary angioedema. Thank you. That was all for the treatment, investigations, and physical findings in urticaria.